Hello, good evening, everybody. Greetings from Hetero. I'm Dr. Prashant, welcoming you to this webinar, Difficult to Treat Autoimmune Diseases. Doctors will all agree with me, treating autoimmune disease itself is a nightmare, it's a thankless job. Today we have got a webinar on this topic. Hetero Doctors, as you know, is an innovative pharmaceutical company marketing products in multiple therapy areas. Besides dermatology, we also market products in ortho, respiratory, women's health, and so on. We have got a very strong R&D and we develop product with improved patient compliance. We have developed product based on patient's need. We market NSAID patches to improve patient compliance and ultimately hoping to have better treatment outcomes. We all market luliconazole lotion with a film forming technology, finally to improve clinical outcome. During COVID time, we were marketing favipiravir, remdesivir, as you know, during COVID time. Today evening, I have the pleasure of inviting moderator for today's meeting, Senior Dermatologist Dr. Sapre and Speaker Dr. Rajiv Sharma. It's an honor for me to share and welcome Dr. Sapre, who has been my teacher in Grant Medical College and JJ Hospital. When we were crawling, sir was holding our hand and helping us to walk and through the years of medicine and ultimately dermatology. Dr. Sapre, as we all know, is MD FCPS, Honorary Professor Dermatology, Venereology and Leprology, retired from Grant Medical College and Sir JJ Group of Hospitals. He is a consultant dermatologist, venereology, leprology, HIV/AIDS in Bridge Candy Hospital and SL Raj Hospital in Fortis, Mumbai. He is trainer for fellow program in HIV/AIDS IIDVL. Dr. Sapre is ex-president IIDVL, member of IIDVI, SIG for dermatophytosis since 2 years, ex-president for College of Physicians and Surgeons, Mumbai. Sir has delivered 1,170 lectures across country and represented the country at over 108 international events. Dr. Sapre is an editorial board member, IIDVL Textbook of Dermatology, IGSTD, IJD. Sir has 45 plus peer-reviewed publications, chapters in medical textbooks, 55 plus presentations, papers presented in international conferences. Dr. Sapre has organized several national conferences in STD AIDS 1998, HIV/AIDS therapy 2007, 2009, 2011, 13 and 15. Dr. Sapre has an international collaboration in academic research with Harvard University of Public Health, Johns Hopkins University, University of Yale, University of Toyama and Osaka, University of KwaZulu-Natal, University of Roma, amongst many others. Dr. Sapre has achieved a Lifetime Achievement Award conferred by Indian Medical Association in 2017, Lifetime Achievement Award offered by Indian Association of Dermatologists, Venereologists and Leprologists in 2018, Maharashtra. Best Practitioner Award at Dermacon International Congress 2019 held at Bengaluru. Recently, Dr. Sapre has published an article on open-label single-arm study to find tolerability and efficacy of fluconazole in patients with tinea corporis and Dr. Sapre has special interest in psoriasis, atopic dermatitis, and urticaria. I can go on and on, but for want of time, so I'll close here and hand off the session to Dr. Sapre to take the proceedings further. Sir, over to you.
Okay. Thank you, Prashant. And I must thank Hetero Pharma for giving me this opportunity to conduct this webinar. But before that, can you project the slide of Dr. Rajiv Sharma? Yeah, today we have got a webinar on use of immunosuppressive drugs in dermatology. And I'll be a moderator. We have panelists, Dr. Rajiv Sharma. Dr. Rajiv Sharma has got very good experience. He's practicing for last 34 years as a dermatology, and his special interest in the pediatric dermatology. Apart from that, he was a former Honorary General Secretary of our national organization, President of the Indian Society of Pediatric Dermatology, and Secretary General of International Congress of Dermatology. He is a member of editorial board of many our journal, IJDVL, IJD, ISPD, and he is a fellow of many international dermatology associations. He has got many more publications, more than 75 publications. So we have got one of the best panelists for today's program. And we'll start this program. Before that, I would like to take one minute for sharing my slide. So Manor, I'll be sharing my slides. Huh? Where is this? Yes. Yeah. Yes. Yeah. One second. Slideshow from the beginning. Yeah. Yeah, it's okay.
Yeah, sir, it's okay.
Yeah. So today's program is, of course, all of us, all dermatologists across the country, we are facing a lot of autoimmune diseases. And autoimmune diseases, last few years, we have started using immunosuppressive drugs. Of course, longer than that, but there are many drugs. So we'll start with Raju. We'll start with the first questions. What are the drugs are available in our dermatological practices where we can use for autoimmune diseases? Raju, can you hear me?
Hear you. I can hear you, sir, very well.
Yeah.
Sir, the drugs that we have been using for years is methotrexate, azathioprine, cyclophosphamide. We have retinoids as such as though they are not really immunosuppressives.
Yes,
We have mycophenolate, mofetil. Then we have biologics. We have oral biologics like apremilast, and then we also have the JAK inhibitors which have come recently in the market.
Yeah. So
Steroids, we all
Yeah.
know are part of our armamentarium for every autoimmune disorder that we.
Yes, as Rajiv has mentioned, we have got now many immunosuppressive drugs or for the autoimmune diseases, but most of the drugs we are using for many years. But one of the now latest drug for last 4 years, which have come in the market, the JAK inhibitors. It's very difficult to discuss each and every drug. So today we are going to discuss about the JAK inhibitors. So JAK inhibitor is one of the novel drugs in our today's dermatological practice. So what is this? What is called is, of course, JAK inhibitor. There are many drugs, but we are going to discuss specifically tofacitinib. And mainly the Indian clinical experience more than just the clinical trial. So what is the tofacitinib? Tofacitinib that we know is a transducer and activator of transcription. And it is an intracellular signaling pathway upon which many different pro-inflammatory signaling pathways converge. So that if you block this pathway, we should be able to manage or treat the diseases which are inflammatory diseases, because most of the inflammatory dermatoses, they require this signaling pathway, and if you can block it, we'll be able to treat this. So what is the JAK inhibitors? What is the JAK inhibitor? We see JAK inhibitor is an immunomodulator which inhibits the activity of one or more of the Janus kinase family, that can be JAK1, JAK2, thereby interfering with JAK and STAT signaling pathway in lymphocytes, which is required for the production of cytokines. So now, what is the mode of action? We know that what you require whenever there is the cytokines, when you get activated, comes in contact with the receptors, there is activation of the JAK phosphorylation, and the JAKs gets combined with the STAT, and there is JAK-STAT formation, which is called dimer. These dimers get translocation in the nucleus and start transcription and producing cytokines. So these are the inflammatory cytokines. So if you block the JAK inhibitors, there is no production of cytokines, there is no inflammation. This is how is action or mode of action. There are various JAK inhibitors like tofacitinib, ruxolitinib, baricitinib are many. But today we are going to talk about the tofacitinib. So Rajiv, I'm coming to you. What are the indication where you can use tofacitinib?
Sir, as such, if you look at the approval, it is only for psoriatic arthritis and the polyarticular juvenile idiopathic arthritis.
Yeah.
But in dermatology, we are using extrapolating its action in different autoimmune disorders. So we have used in psoriasis, we have used in alopecia areata, vitiligo, atopic dermatitis, and some people are even using in lichen planus.
Yes.
Morphia people have used,
Yes.
scleroderma people have used. So people are trying it now in everything because now it is freely available to us.
Yeah, so as Rajiv said, these are the 4 conditions we are using it. But as he has mentioned, there are other conditions where there are studies where the small number of patients are studied. So they can be used in dermatomyositis, chronic actinic dermatitis, erythema multiforme. There are many, and there are anecdotal examples where it can be used in B-cell mediated disorder, interfacial pyoderma gangrenism. So you mentioned, I think Raju, agree, most of the inflammatory diseases are included, correct?
Yes, sir.
Yeah. So these are the various indications. But today we are going to discuss, I am using this drug for last 4.5 years. So what are the cases we can use it and where you can get the result? So Rajiv, I'm going to discussion with the first case. This is a 45 years old male. He came with the chronic plaque psoriasis suffering for 5 years. The patient has got comorbidity, diabetes, hypertension, and is on the various drugs for diabetes, hypertension, and cholesterol. We started on the topical treatment, there are hardly any improvement. So of course, and these patients are extensive lesions, we started this patient on cyclosporine, 100 milligram BID. Patient was doing well. But when a patient was doing well, after a few months, his blood pressure started rising, and serum creatinine started also going up. So now what we should do to this patient? Rajiv.
Sir, if possible, I would prefer to give him narrowband UVB therapy.
Yes.
If that he can come and take.
Yeah.
Otherwise, with all these comorbidities, apremilast becomes the best drug to give.
Yeah.
With the renal issue and rising serum creatinine, even drugs like JAK inhibitors may not be very good.
Yes.
He already has hypertension and he might have dyslipidemia also. So tofacitinib again will cause a lot of problem.
Yes.
So we should be wary of these comorbidities whenever we are trying to use a drug, especially the JAK inhibitors.
Yes, correct. I entirely agree because there are comorbidity. We have to be very careful while using this systemic drugs. So this, of course, we switch this patient to methotrexate. Patient had experience of taking methotrexate, but he developed leukopenia. As he developed leukopenia and the lesions were extensive, and as you said about the phototherapy, there was no phototherapy available in my clinic. We are not giving because in Bombay, being a small place, but I entirely agree that phototherapy is one of the options. So now, Rajiv, what we should do?
Sir, I said apremilast is a drug worth going to.
Yeah, but apremilast, Rajiv, still they say it sometimes it works, sometimes it doesn't work. Even
same is true for most of the drugs, sir.
Yes, correct. Yeah, and it takes a long time. So what we did, we started this patient on JAK inhibitor, tofacitinib 5 milligram BD. Even there was dyslipidemia that we control with the using rozulip. And see, after 4 weeks, everything disappeared. So this is, I'm talking 4.5 years before, when there was hardly any solution. And this is how we have got result with the tofacitinib. But the question came that whenever the patient of psoriasis come, they want immediate results. So it took 4 weeks. So as a rescue therapy, when you want immediate results, of course, drug of choice, according to me, cyclosporine. Raju, you agree?
Yeah, exactly, sir. The fastest acting drug is cyclosporine.
Yeah, but then, so what to do then? There was another patient where I started, see, this is extensive, lot of erythema, extensive lesions, but we started on tofacitinib, and after 2 weeks, if you see, there are hardly any inflammation. So this tofacitinib also, we realized we can get the quicker results. So we'll go for the next patient, Rajiv. This is another patient of pustular psoriasis. But again, she was suffering from 2 to 3 years. There is a comorbidity, diabetes with the old patient, hypertension. In spite of that, of course, there was no choice. So we treated with a 40 milligram of steroid with antibiotic. But how long we can go on steroid in this patient? Rajiv.
Sir, either we can give her acitretin
Yeah.
if you can maintain, or again, your favorite drug you can try, but still with DM and hypertension
Yes.
and such red eye, I think I would like to avoid JAK inhibitor.
Yeah. Okay. Yeah. Anyway, so this patient, Abu Pesulimab, now it is available on the clinical trial or extended trial, but that drug was not available because today we can always ask for Pesulimab, but this drugs was that time was not available, and this patient has got hypertension, diabetes, where even the methotrexate or even acitretin we can use it, but acitretin take longer time in the
3 weeks.
there was nothing, so I said, let us try something. So this patient, we started reducing prednisolone or tapering prednisolone and introducing tofacitinib. And now, at the end of almost 4 years, this patient is taking 5 milligram of tofacitinib once in a week. And you'll see, this patient came about 10 days back to us. She is doing very well. There was no flare-up. There was no recurrence. So I thought I'll just share my this experience that we can maintain this patient on tofacitinib without steroid, because steroid is got a lot of limitation because of the age, hypertension, and diabetes. And there are literature, according to literature in psoriasis, almost 75% improvement you get. There are 339 trial where they 75% of the improvement you get in psoriasis area and severities. So this is one of the good drugs for psoriasis, and that is my experience also. Only thing when you are using in psoriasis, it depends upon the dose. When the dose is high, that is more than 5 milligram, 10 milligram, the results are better. And they have compared with the etanercept, one of the biological, and they found it is non-inferior to etanercept. Topical also you can use it, but if there are limited. So this another condition.
But sir, may I interrupt? Sir, giving a higher dose will mean more side effects can occur, especially the dyslipidemias and the intravenous coagulation and all that. Those things can occur. Deep vein thrombosis can happen. The frequency of infection, especially the UTI and renal infection, increases. So we should be very careful when we are using high dose of tofacitinib. And we should be monitoring our patients very regularly. It should not be said that it is a good drug and it can be used without any caution.
I entirely agree. Dr. Rajiv has given very good suggestion, and which is I was going to cover in the next, but we'll cover here only as it when comes. Whenever using the higher doses, you have to monitor this patient very closely. You are when they are on two. Usually, I start with the 2 BID 10 milligram BID. There you have to monitor this patient every weekly till the doses are higher. I entirely agree. So we have to be very careful. Yeah. This is the next patient. This is a patient of atopic dermatitis. He was on steroid for 1 year. Again, he has got, see, most of the patients, they come to us, they got a comorbidity. Yes, correct. So we again started this cyclosporine, but again, there was a problem of this renal side effects. We started methotrexate, but patient developed again blood dyscrasia, but the patient was given adalimumab, but there was a relapse. And this patient was from far. Then I said, why not to start new drug? So I started this patient on tofacitinib, but I'm not showing this patient for tofacitinib, but you know, Raju, we
Side
are
effect.
talking about the side effects.
Yes.
Patient told me from Lucknow, sir, why did not you start this drug before? I said this drug was not available. He was very happy. After 1 month, he said, sir, I'm getting severe body ache.
Body.
So what we should do to this patient? Because these are the problems you are going to face when you start using tofacitinib.
Yeah, sir. We have to investigate for myo inflammation. Muscle inflammation can be there.
Yes, yeah. So, you know, this patient was getting the body ache. I thought a muscle involvement and whatever theory that time I read, I was thinking of rhabdomyolysis.
Lysis, yes.
Yeah, that is one of the complications. But always we should not be hesitant to ask the people who have got more experience, even they are junior. So the rheumatologists, they were using these drugs for 2-3 years before us. So I spoke to one of the rheumatologists. He said, sir, this is just like your rifampicin. I said, what do you mean by rifampicin? He said, start rifampicin leprosy, they get flu-like syndrome. The same thing can happen with tofacitinib. And he said, don't worry. But you know, just for the safety, I got CPK done and serum aldolase done. You know, that raise when there is muscle damage. But they were within normal limit. So he said, he can, sir, continue those, not to worry. Only thing we have to get CPK done and muscle enzymes. And then you can go ahead. So this is how we are learning. Everybody learn from each other. The next patient of Pomfolics. Again, there was a limitation of using other immunosuppressive drug. We started tofacitinib and patient did very well. So these are the various, of course, there are many trials they have done. Almost, there are 91 clinical trials where they said this is one of the innovation drug in the treatment of atopic dermatitis. We'll go for the next patient. This is another patient. Of course, we are talking about the adult. But I think, Raju, you must be seeing this lot of patient as a pediatric dermatology, correct?
Yeah, sir.
Rajiv?
Sir, what
Hello?
I can, yeah, sir. I'm there, sir.
When you look at this, yeah.
Prurigo.
Just elaborate on this patient. Yeah.
The severe pruritus is there. He has got
Yes.
lot of itching. And
sleepless
probably another.
night, you know. Yeah. So this is a severe case of atopic dermatitis. Yeah, correct, absolutely. So this is a 6-year-old female, severe atopic dermatitis since 2019, taking methotrexate and pulse steroids. Initially, it was given azithromycin and cyclosporine, but there were 90% improvement patient came to us, but complain of, because the patient was cyclosporine, complain of excessive hair growth. So we switched to betnesol, but complain of constipation, weight gain, and increased hunger. Patient started putting on weight so much that 6-year-old girl, she told me, sir, nobody is recognizing me in my class. Everybody laughs at me. So now how we are going to manage this patient?
Sir, now dupilumab is available. If they can afford, we can give that. Otherwise, again, tofacitinib, as you said, is a good drug. It can be tried, but only thing is doses cannot be given like adults.
Yeah, I entirely agree that dupilumab, now we can use it. But then that time nothing was available, so we started using tofacitinib. And with the tofacitinib, you see, this is the picture initially when the patient came with the excoriation, exfoliation, dryness, severe dryness everywhere, involving almost 90% of the body surface area. And after, as you said, we started tofacitinib, 4 milligrams. And see, after almost 3 weeks, everything clear. Yeah, see the back and all, the patient is doing very well. But as you said, we are monitoring this patient very closely. Then we'll go for the next patient, that is alopecia areata. Rajiv, this patient came to me with taken various type of treatment, but he said, sir, I'm not happy. Can you suggest something? So
Sir, the
again, yeah,
problem is he's having universal, almost total loss of hair on the scalp.
yes, correct.
And his ophiasis is very much there. So whatever drug we will give, we will get a response, but there will be a recurrence.
Yes.
So yes, nowadays tofacitinib is being tried, but only thing is now I am seeing patients who are getting patches even while they are on tofacitinib.
Yeah. So, I started on tofacitinib, there was no other option. So within 2 weeks, there was good growth. Patient was very happy. Within 3 months, he got the growth. He said it's like my original growth. He was very happy. But what problem we are saying, as Rajiv said, how we can maintain it? Because the minute you stop it, they will start losing the hair. So how we are going to prevent the recurrence or relapse?
So we can either taper the dose to the minimal possible where we can maintain the hair growth. But people do break out with patches in between if we reduce the dose.
Yeah, it's very difficult. But as Raju said, we can reduce the doses. And as in pustular psoriasis, we are maintaining on 5 milligram once in a week. We can do that, but we have to monitor patient every month about the CBC, because CBC is this bone marrow is the first system is get affected. That we have to monitor, or we can change it to other drug like a methotrexate. But again, methotrexate also you have to manage.
Monitor.
Yes, correct. So there are 254 clinical trial, and they say this drug is very good. But in again, alopecia areata, the higher the doses, the response is better. But nowadays we have topical tofacitinib. So Rajiv, what is your experience about the topical in alopecia areata?
Sir, I'm using in few patches when there are only few patches. I'm not using it extensively in large areas.
Yeah.
In some patches, when there are 2-3 patches, the response is there, but it is not very fast like ILS.
Okay.
But the response definitely is there.
Okay. See, this is the 75-year-old lady came to my clinic, and she has got, of course, a lot of comorbidities. But the first thing she told me, sir, I don't want to take any tablets. Can you treat me? So I said, as you said, I was also under impression, tofacitinib, if there are a few patches, small patches, we can treat. But there are extensive patches, there are a large area of the scalp is involved. We may not be able to treat with the local. That was my assumption also. And then the first thing we wanted to know, is it alopecia areata? So we did a biopsy because we have to confirm whether it's because of the aging process or. So we did a biopsy. This patient, of course, her hemoglobin was less, 7.2 gram. So we did a biopsy, and see the biopsy report came alopecia areata. Till then, and we started this patient. We started this patient on tofacitinib local application. This patient came yesterday, and I was surprised. See, she has got such a nice growth, hair growth. She was very happy. So similarly, I have treated some patients with extensive alopecia areata, and they are also doing very well. But this is my experience for last 1 year. Before that, as Rajesh said, I used to use only limited lesions or the small lesions. But now we are getting very good experience that extensive lesions also you can use it without giving systemic drugs. But of course, we need a large number of patients. Yes, Rajiv?
Sir, most of the companies are now withdrawing the gel form. Now, which company is still having a gel form? Most of them are coming with ointment form.
Yes, correct. It's a very good question. See, there is one Topadose. MSN, they have got a gel form.
Oh, okay.
Yeah. I agree. I am using that only, gel form, because of the hairy area. Correct. So tofacitinib in alopecia areata, it works very well. Then Raju, this is the patient is little bit, we want some variation, other it becomes a monotonous, This patient had chronic plaque psoriasis. We started on tofacitinib, but then he came with this type of lesions. Can you see there is? He
Hair
said,
loss.
I have started losing my hair. Is it because of tofacitinib? So when we saw this patient, at least I saw it looks like a male pattern.
Male pattern. Male
Yeah.
pattern. Exactly, sir. Male pattern hair loss only.
Yes, correct. So I said, but he came with a bunch of hair, losing bunches of hair. He came like most of the ladies patient, they come with like this, no?
Yeah.
Yeah, but he
Telogen.
said, I'm using. Then I said, this is not male pattern. Male pattern, we do not get this type of thing. So what you can think of?
So diffuse alopecia areata or
Yeah.
a telogen effluvium induced by a drug.
Yes, correct. So then we asked this patient history, he had a COVID 2 months ago before he getting this.
Oh, sir, he was on tofacitinib also while we had
Yes,
COVID.
correct. But he had a COVID. COVID is also one of the common cause because the tofacitinib I'm using for last 4.5 years. I have not seen a single patient who complained of loss of hair. About my 500 patients are on tofacitinib.
Oh.
And I'm following there for last 4.5 years. Many patients are more than 2 years. Some of the patients are for 3 years. So we said probably because of the COVID, because COVID is one of the most common cause of the diffuse hair loss. Telogen effluvium, it was telogen effluvium. But as you said, any drugs can give rise to in an individual, it can
Acute
be individual variations. Yeah, you
Yes,
have to keep that thing in mind. Then this is another patient of lichen planus. Again, 73-year-old patient. And if you see, she has taken all available immunosuppressive drugs like methotrexate, cyclosporine, azathioprine. When she came to me, I said, first, let us find out because she has got hypertrophic lichen planus and it is there for long. We did a biopsy. So biopsy shows hypertrophic lichen planus with pseudocarcinomatous hyperplasia because better to rule out, Yeah, so we started this patient on tofacitinib. Even she was 73 old because we have to, I have learned to monitor very closely and see after 2 months, everything cleared. She was very happy. But after some time, she told me, I'm getting swelling of my foot. So Rajiv, what is it?
So we have to rule out deep vein thrombosis. We have to rule out cardiac side effect.
Yeah, but it was unilateral. I agree. If it is a bilateral, cardiac.
Otherwise, venous occlusion, sir. We have to think of venous occlusion.
Yes, correct. Whether it's a DVT or something like that. But she was complaining of pain also. It was very painful. So, of course, it was cellulitis.
So some infection. Okay.
Yeah, correct. So now the patient gets cellulitis, whether you would like to continue tofacitinib or you would like to discontinue.
Sir, we can try giving a good antibiotic, but if it is recurrent, we have to withdraw the drug.
Correct. So whenever there is any infection like a bacterial infection, opportunity infection, better to stop this drug. So as Rajiv said, we have started on linezolidine and within 2 weeks, everything disappeared. So now we can start, but we have to start with the low doses.
Lower dose.
Yeah, lower doses and patient is doing very well. So what are these side effects? One of the cellulitis we have seen, but there are many more side effects. So Raju, can you just make...
Sir, the commonest that I have seen in patients is a urinary tract infection or upper respiratory tract infection.
Yes, correct. Yeah.
And then any infection, whether virus, fungus, or bacterial, can happen in patients who are immunosuppressed with tofacitinib.
Yes, correct. And one of them is bone marrow suppression. Yeah.
That happens the first you told, sir. That is the first sign.
Absolutely.
Drop in hemoglobin and count, we have to keep up.
Yes, correct. And as you said, before starting tofacitinib better to rule out the risk for DVT, because that is more dangerous. So these are the patient, obese patient, patient with myocardial infarction, heart problem, hormone they are on contraceptive, better to avoid, otherwise you have to monitor them closely. So this is, will go for a next patient, that is 60-year-old man, is a doctor by profession. He has got hypertension, chronic kidney disease, serum creatinine is 5.5, and he had even pulmonary coughs. He came with the extensive bullous pemphigoid. When patient came, we did a biopsy. Biopsy shows bullous pemphigoid. So Rajiv, how we are going to treat this patient?
Sir, again, very tricky in such conditions
Yeah,
where there is
very,
renal failure.
Yeah.
So if it is limited disease, topical potent steroids are good enough.
No, it was very
If
extensive.
it is very extensive disease, then if you are contraindication of steroid is there, then definitely we have to go for some immunosuppressant. Kidney is damaged, we cannot give cyclosporin, methotrexate
Yes.
will take long to kick in.
Yes,
So
correct.
we are left with JAK inhibitors, then again we will have to try and take the risk.
Yeah, so why not to start with the tofacitinib? The question comes in this patient with drug-drug interaction. Because these are multiple drugs. So I thought I'll just cover the topic of the drug-drug reaction.
Yeah, cytochrome.
Yeah, this is because the metabolism tofacitinib through CYP3A4.
Yes, sir.
So either the drug is inducer or inhibitor. If the inhibitors, then the toxicity is more. If the inducer, then the effect may go off, or we may not achieve the effect. So we have to find out the drug. So this patient, because the TB, in TB we did not give rifampicin, we give him moxifloxacin, and we started tofacitinib. And this patient is doing very well with the tofacitinib. Only thing, we are managing his CBC very closely every week, because this is the only drug we can use it, and the patient is doing very well. I'm going to come follow up that patient, I'll show you. But this is another patient came, again 77-year-old patient with again history of comorbidity. We did a biopsy, and biopsy shows this again bullous pemphigoid. So we started this patient on tofacitinib. But if you see, his platelets started dropping down to 84,000 after 10 days. So now what we should do?
Sir, you are giving two drugs, rituximab also with tofacitinib.
Yeah, this patient was given the rituximab, correct.
Because normally it is said these two should not be given together.
Yes, correct. Yeah.
So if the platelet count has dropped, we'll have to either decrease the dose, monitor the platelet for a long time. If it still drops, we'll have to withdraw.
Yes, correct. I entirely agree. As Rajiv says, we get scared, but do not get scared. This is dose related. When you reduce the dose, see, after 1 week, his platelets came back to normal. So don't get scared. This can happen. And what even hematologists will do, they will reduce the dose. You reduce the dose, and as you said, if the recurrent, you have to stop. You cannot continue. So we did this. But you know what patient do they do?
On their own.
Correct. So this patient started becoming better. He started taking this drug himself without coming to for follow-up. And see what happened. After 3 months, he said, "Doctor, I'm not able to walk. I'm feeling very weak. I'm not able to eat." I said, "Get a CBC done." And if you look at CBC, everything report is bizarre. So the message here that I remember Dr. Fitzpatrick has written about methotrexate in his book. It has to be dispensed from the clinic. It should not be prescribed. The same thing I'll request all dermatologists, don't prescribe, dispense. When you dispense, they'll come for follow-up. If you do not dispense, they will buy from the market. They'll keep on taking, and they'll end up with a lot of problems like a bone marrow suppression, liver toxicity, bone toxicity, everything they can. So we have to be, as Rajiv said, we have to be very careful, because patients they start taking their own, they become all right. So,
Sir,
yeah.
Sir,
Yes,
the problem is Now even BMS, BUMS people are writing tofacitinib. So
That
we may be as cautious as we want. We always end up with getting complicated patients who have got some problem due to the drug.
yes, correct, absolutely. So now I think this is the things where we are not able to, we do not have any control.
Control. Yes.
As far as possible, I keep on telling all pharma, if you are going to promote with general practitioners, I won't prescribe that drug. At least, see, everybody should contribute a little bit, then it may be effective, you know.
Right, sir. Right.
Yeah, that's right. So it's a dose dependent. This is another patient of libido vasculopathy. This patient was taking treatment for 2 years, but by the time he came to my clinic, see, is a typical presentation. Anybody can see the clinical pictures. Chronic disease is a vasculitis. I said he has used all drug, let us try. Yeah. And then again, I started this patient on tofacitinib, but always this severe disease, initially first at least 1 month, I start with 10 milligram BID, that is 2 BID, 5 milligram. Now 11 milligram is available, so 1 BID you can give. And this patient, within 2 weeks, the patient was bedridden, he was not able to walk. After 2 months, he started coming for a walk, and where I go for the walk, there's a place called Shivaji Park. He comes with me and he walks for 3 miles. You know, so he was very happy. But as Raju mentioned, you have to monitor very closely and start tapering. This patient is on this drug for last 2 years.
And sir, it should not be the first go-to drug.
Pardon?
We should not take it as the first go-to drug.
Yes,
When
yes.
everything has failed, then only we should give.
Yes, correct. This patient has already tried. He was under treatment for last 2 years with my other colleagues, and that's why I tried. But this patient came about 2 months back. He has developed breathlessness.
Now,
Then I took the opinion of chest physician. They said, sir, now he's developing vasculitis in the lung.
lung.
So we have to add steroids. So now this patient has put on 40 milligram steroids and is doing well.
So, sir, was this patient having PAN, polyarteritis nodosa?
Yeah. When he came to me, he was not able to walk. He was bedridden because of pain, severe pain. Yeah, that was the complaint. See, now we'll go for another patient. This is another 65 years old patient, father of one of the doctors. He had multiple erythematous plaques involved in the trunk, both extremities, again with lot of comorbidities. When he came to me, Raju, what do you think if this type of patient comes with the erythematous plaques, chronic? What do you
The
think of?
fever, pain, if chills
Yeah,
and
fever
rigors
was
are there,
also there. Fever was
then
also there.
erythema nodosum leprosum is one of the diagnoses that we can make.
Yes, I also thought of whether dealing with a lepra reaction to type 2. So we did a biopsy because his previous 2 biopsy was showing a leprosy. The patient was treated for leprosy. So we did a biopsy because we wanted to just confirm it, and it turned out to be lupus erythematosus.
But sir, the lesions are too many, too extensive.
Yeah. I entirely agree. Because I said, let us see, because any patient with coming with a chronic disease, better to confirm. Then I got the history. He was diagnosed as a SLE about 5 years before in one of the hospital where he was on chloroquine, he was on methotrexate, he was on azathioprine, many drugs. But he came with this, he landed up with a dermatologist. They did a biopsy, and biopsy for diagnosis of leprosy at 2 places. I was surprised. So we diagnosed as a SLE, we took opinion of rheumatology. And as you said, we started on tofacitinib.
Sure.
And see, after 1 month, everything is under control. And this patient I'm following is the father of one of the doctors for last 2 years. He is doing very well. So this was a case of lupus erythematosus. This is another patient. This patient came with history of some growth on the corona. When he came there, Rajiv, what do you think of this patient comes to your clinic with a 2 years growth?
Sir,
I thought of whether I'm dealing with a CA, squamous cell.
CA. Yeah, looks like, sir. Keratotic, either cutaneous horn or a CA.
Yes, those are the differential diagnosis, correct?
Yeah,
So,
but LSA also seems to be there. Lichen
Yes.
sclerosus also is there.
yes, correct. That was another differential diagnosis. So we did a biopsy, and as Raju says, it turned out to be balanitis xerotica obliterans.
Public.
Yes,
Lichen
absolutely
sclerosus.
right. So we started this patient again within 3 weeks. See, everything cleared. The patient was surprised, and of course, I was also surprised. So these are the clinical experience we are sharing. Of course, in urticaria, a lot of patients of urticaria, we are using it. But what was surprising, this patient came to me, 20-year-old patient. She had a severe acne, very inflammatory acne. She was on the treatment for last 2 months, but she wants to get married. She has taken isotretinoin, antibiotic, everything. So when she came, I said, okay, these are inflammatory acne. So Rajiv, how we are going to manage this patient? What
Sir,
do you suggest?
I would give her a good course of antibiotic with anti-inflammatory. In 2 weeks, it will go. But definitely, if it has been persistent and recurrent, we have to subside the inflammation only.
Yes, correct. So I thought of giving systemic steroids because small dose for a small period we can give.
Yeah,
But as she heard steroid, she said, no, sir, no. I think that's a usual reaction, no?
steroid phobia is there, sir.
Yeah. Inflammatory acne, we give steroid for a short course.
Yeah,
The
we can give.
inflammations, yeah. So this is the pictures from all angle. So we started this tofacitinib to BD and see the picture exactly after 3 weeks. Of course, along with isotroin and tofacitinib, because she has taken isotroin in the past, and we explained about the teratogenicity of isotroin because she was getting married. She said, no problem. And this is exactly after 3 weeks of tofacitinib. So these are the
Great.
various indications we are using it. Okay. So about the monitoring, so Rajiv, before starting tofacitinib, what investigation would like to get it done?
Sir, we have to get CBC, we have to get LFT, we have to get RFT, we have to get lipid profile. Then we have to look for tuberculosis, so IgRA and Montux. We have to get then the viral markers, the 3 viral markers we have
Yes,
to
correct.
get. And after that, we can decide whether we can give or not.
Yes, correct. Absolutely. We have to rule out any underlying active infection.
Active infection.
Yes, correct. Okay. So, and then you have to follow every month or 3 months for the at least CBC or renal function and liver function. But if you are using higher doses, till the higher doses there, I would like to suggest follow CBC every week. Or
Yes,
every
sir.
2 weeks. Yeah, that's the, because bone marrow suppression is a common side effect. Okay, so what are the contraindications? The same thing about the contraindication, what we have mentioned here. Only thing about the hematological abnormality is very important. Absolute lymphocyte count, absolute neutrophil counts, and the hemoglobin less than 9 grams, better not to give these drugs. Okay, these are the contraindications. Raju, you would like to add anything?
No, sir, this is more than enough. And in lactation, we should be very careful.
Yes, pregnancy and lactation, correct, breastfeeding, correct. So, coming about, we are always worried about tuberculosis. So, how many cases you have seen of reactivation of tuberculosis patient on tofacitinib?
Sir, I have seen at least 2. One child got lymphadenopathy, tubercular lymphadenopathy.
Yeah.
And one had reactivation of pulmonary tuberculosis. And one recently I saw was IgRA positive, had a fibrotic band in the lung and was on tofacitinib and was complaining of breathlessness and coughing.
Okay.
So I sent to the pulmonologist.
Yeah. But these patients were given prophylaxis Isonex or not?
No, sir. The pulmonologist there where the patient was given did not advise anything. They said you can go ahead with tofacitinib.
Okay. So
prophylaxis is a must, sir.
Yes, correct. So we'll keep this in mind. I'll cover. So, When you want to rule out before starting tofacitinib, better to rule out what is called latent tuberculosis. More than active tuberculosis, we can rule out because they have signs and symptoms. But we have to rule out latent tuberculosis. To rule out latent tuberculosis, there are two tests be done. Even in the CDC, they recommend either you do IGRA test or Montu test. Both tests are not required because there is a lot of misunderstanding. These are the slides are picked up from CDC purposely because you need either empty Montu test, otherwise you do IGRA test. In America, they are using IGRA because that is a cheaper. Because Montu test, the patient has to come twice for reading, so it becomes very expensive. So in America, they are using IGRA. In our country, Montu test is very reliable. So one test is enough, no need of doing both tests, because a lot of rheumatologists are also confusing our dermatologists. And unfortunately, dermatologists feel rheumatologists are the better physician. No, I got experience about tuberculosis in last 30 years that Montu test is more reliable than any other test. Of course, we have to get chest X-ray and ESR. So these are the clinical trial. In this clinical trial, the patients who were given the 9 months isoniazid or 1 month of isoniazid before starting, when there were patients of latent tuberculosis, none of them developed TB because this is the use trial from the rheumatologist. So before starting tofacitinib, better to rule out latent tuberculosis. And if there is latent tuberculosis, cover with prophylaxis, they won't develop tuberculosis. Again, there is another clinical trial where this patient developed tuberculosis, poor patient, but here they only look for active tuberculosis. They did not look for the latent tuberculosis because they treated active tuberculosis. So latent tuberculosis is important. This is the message. Before starting tofacitinib, please look for latent tuberculosis. So this is the another same patient of mine, that bullous pemphigoid. After some time, he came with this type of rash. So Rajiv, what do you think?
Herpes zoster developing in the patient.
Yes, correct. So whenever they get this herpes zosters, according to me, last 4.5 years, I have seen a few cases, not more, but they come with 1 or 2 lesions, not more than. The lesions are mild, not as like what you see the conventional. These are the patients where, because the immunocompetent patient, they can express well. So the lesions are extensive, while immunosuppressed patient, their expression is less. So lesions is mild. Usually we can stick with acyclovir, and at least I'm continuing this patient, but on lower doses, not the higher doses. This is another patient who was on tofacitinib. Rajiv, he came with this type of lesions.
Tinea is there.
Yeah, so we have to be also careful of the tinea. You can start, yeah. This is the another patient, he came with a papular eruption on the face.
Demodicosis or maybe herpes simplex.
Yes, so we did a scraping and we could demonstrate demodicisis. Absolutely right. This is demodicisis. We started with the ivermectin and metrozine. This is another patient. She developed multiple.
Molluscum.
Yeah. But these were the plain warts, verruca plana. Okay. You know, these are the things we are seeing. This is another patient. He had oral lichen planus. He developed
Candidiasis.
Oral candidiasis. So we have to keep in mind about this. But this is a very, what is it, a price case. This patient was admitted in ICU. One of my patients of bullous pemphigoid on tofacitinib, he kept on taking himself for 6 months, and he landed in the ICU in the Bridge Candy Hospital where I'm attached. And when I was called to see this patient, he had Osler nodes and Janeway lesions. Yeah, so what do you think of
So maybe subacute bacterial endocarditis.
Yeah, absolutely right. It was infectious endocarditis.
No.
The patient land up because the immunity gets suppressed. So you have to be very careful. Again, I'm repeating, as Raju mentioned, that don't prescribe, dispense from your clinic so you know that patient will come follow and they won't keep on taking the drugs because they're all right. So these are the complications I have seen. Another, this is one of the patient. Raju, what do you think she has got sunken nipple?
So nickel has gone on inside, so maybe a
Yes.
malignancy.
Yeah.
Yes.
Yeah, ductal carcinoma, because they have not mentioned, but this is my experience. This patient was on tofacitinib. After 1 year, she came with this. Then, of course, so we also we learn by the hard ways that because if you go for the clinical trial, say the incidence of the malignancy as good as the patients on placebo. But then my experience, any patient is a female, when you want to start on tofacitinib, better to rule out under malignancy, that is urogenital malignancy, or breast in the female, and prostate and lung cancer in the male. At least if there is no history of cancer in the family, at least you take this history before starting. That is my suggestion. Rajiv, you want to add anything about?
No, sir. Exactly what you are saying is absolutely correct.
Yeah.
Even family history, if it is there, is very important when we are giving such drugs.
Yes, correct. So safety profile, of course, there are clinical trials for 8 to 9 years, and they found there is hardly any tuberculosis or malignancy, but we have to be very careful about tuberculosis and malignancy. Then about the involvement, if there is involvement of the liver, of course, unless and there is a severe involvement, grade 3, then only you should not. Otherwise, renal, we can use even this CKD patient you can use, but the dosage should be small. Raju, I would like to want to listen to you. What are the doses in the pediatric?
Sir, same as you have mentioned here, we should try to give the minimum possible dose in the children according to the weight, according to the age. There are 2 divisions. According to the weight, as you have mentioned here, 5 milligram 2 times a day if weight is more than 40, and if less, then we can give 3 or 4 milligram per day.
Yeah,
So,
doses
but
are very important. Yeah.
But now the syrup form, I think, is available as you have told, sir.
Yeah, it's a 5 ml contains, 5 ml syrup contains 4 milligram. Yeah.
4 milligram.
Yes, correct. So pregnancy, lactation, we have mentioned about this. Then, of course, this is one of the clinical trial. They say apremilast is the right drug to combine with tofacitinib, but rheumatologists, they are combining with methotrexate and tofacitinib. Yeah. So you can combine this. I think before closing, I would like to just bring it to your notice. I'm writing book on Indian Atlas of Regional Clinical Dermatology. It will be ready after 2 months. And here, even it is a color atlas, we have involved clinical diagnosis, some of the spatial investigation like dermoscopy, histopathology, and we have mentioned any spatial treatment. So I hope this book will be useful for most of you. And I think I'll stop here and I'll stop sharing, and I'll hand, if there are questions, I think Raju, both of us have to answer.
That's fine.
I'll stop sharing.
So there are a few questions.
Yeah.
One is someone said that a patient at topical solution, gives a lot of burning effect. I mean,
exactly. Initially, when you apply, the ointment form gives a lot of burning in some products, not in all products, not in all brands. In some brands, it does.
Even the solution gives burning?
The gel doesn't give. The lotion, I don't think, is available.
Okay. And does the risk of stroke increase in patients above 50 years?
Yeah, they said any patient above 70, elderly patient, better not to start the drugs. And if you are starting, if there is cardiovascular diseases, you have to be very careful.
Yes, sir.
Especially when there is a dyslipidemia. Better not to start the drugs, and if you want no other option, you have to monitor very closely.
Absolutely. Right.
It has to be a multi-system. Yeah. It has to be a multi-system approach. You
Yes,
cannot do
Absolute,
it
absolute.
single-handedly. You should
No,
have a
no, no.
cardiologist,
Correct,
neurologist
correct,
on your
correct.
side.
It's a group treatment finally.
Yeah.
We do a TB testing for every patient we start on put on tofacitinib or TB Gold as we call.
no, can you
TB
repeat
test.
this question,
The
Prashant?
TB testing should be done for every patient before we put the patient on tofacitinib.
I think each and every patient you must do Monto test, chest X-ray, and ESR. And if
Absolutely.
a patient is affording, you can get even IGRA.
Absolute. It's better that way.
Yes, correct.
Anyway, thank you so much, doctor. Thank you, both of you. It was a lovely session, eye opener to many of the problems. We know that efficacy is good, at the same time, safety and be sure is another important thing. Thank you very much. It was a lovely session. The case studies were really good. I also
Thank you, sir.
take this opportunity to thank all the field personnel of from Hitro, the marketing team of Hitro, the IT team of Hitro, whose support is endless, for this type of meeting. Thank you so much, all of you, and then signing off. Thank
I
you.
think-
A very good evening.
I think once again, I must thank you, Rajiv. It was
Arey,
really
sir.
wonderful experience you shared.
True.
I think the message has gone to our colleagues.
Very
and I
true.
must thank Edro, Prashant,
Yes.
Manohar, and your team and technical team. Thank you.
Thank you, sir.
Good
Thank
night
you.
Thank
and
you
have
very
a
much.
nice
Thank
day.
you.
Thank you very much, sir.
Thank
Thank you.
you. Thank you. Signing off. Thank you.
Okay.
Okay.